And so the question is, do you get treated when the disease is most curable, or do you get treated with something more intense later? Following cancer can cause anxiety for some patients. It's important that they have counseling with their physician. It's important that they have networks like yours that are talking to patients about surveillance as being common, but it can be anxious to follow your cancer. And following patients on surveillance requires more frequent follow-up visits and requires some procedures like biopsies over time. So let's think about who are the ideal candidates for active surveillance and how we decide who we're going to put on surveillance and how we're going to follow them. A lot of it is like, what is that man's risk up front? So how do we determine their risk? There are things like their Gleason score, which is the Gleason grade under the microscope. There's things like how much volume of disease do they have, even if they have low-grade prostate cancer. What's their molecular risk? And we'll talk about this. And then there's characteristics of the man themselves that maybe are apart from the disease that you've diagnosed. And those include the patient's age, their race, and their genetic makeup. And we'll talk about all of these things in the following slides. So when we talk about active surveillance for clinically localized prostate cancer, we're really looking at observing with favorable risk disease, so disease that we think could be observed. And who are those men? So the broadest in broad terms, there are these three categories of National Comprehensive Cancer Network risk states. Clinically localized very low risk disease, and favorable intermediate risk disease. Very low risk disease is that prostate cancer which is of the lowest grade, 3 + 3 = 6, Gleason grade group 1, and very low volume of that disease. You know, three or less cores, PSA density that's less than 0.15, meaning that the prostate itself will make PSA. And so you want to know, where is this PSA coming from? Is it coming from most of the prostate, or is it coming from the prostate cancer? So someone with a 40-gram prostate who has a PSA of 4 has a PSA density of 0.1. Someone with a 20-gram prostate and a PSA of 4 has a PSA density of 0.2, and that PSA density would be very concerning. But very low risk disease is low volume, low grade disease, PSA density is low, signifying that most of the reason the PSA was there to begin with was because of the large prostate. Low risk disease is different. It's low grade disease still, Gleason grade group 1, 3 + 3 = 6, but more of the prostate's involved by it. A person with 6 cores on the biopsy positive for Gleason grade group 1 disease. It allows for PSAs up to 10, and it allows you on rectal exam to feel some prostate cancer. That's what T2A is, so that you can feel 1/2 of one lobe of the prostate might be involved by cancer. But all the diagnostic biopsies showed low-grade disease. Favorable intermediate risk disease is a category of intermediate risk prostate cancer that may have some candidates that are appropriate for surveillance. These are men who have only one intermediate risk feature. So, for example, like their Gleason score is 3 + 4 = 7. They don't have that and a PSA of 15, you know, so just one intermediate risk feature. And these are men that typically have lower volume, 3 + 4 = 7. Some people say less than half of the biopsies have to be positive for prostate cancer. So it's a subgroup of favorable intermediate risk disease. So why are we looking at these three subgroups? Well, these are the three subgroups of favorable risk clinically localized prostate cancer that have been shown to not have a lot of metastatic events or death events if you follow those men for about 10 years. And that's been shown in various clinical trials. And with that realization, the utilization of surveillance has increased. So even from 2010 to 2015, utilization went to about 40% for men with low-risk prostate cancer. But let's dive down into the data even more and really think about these risk groups. So again, there's very low-risk prostate cancer, low-risk prostate cancer, and favorable intermediate-risk prostate cancer as the three groups of favorable, quote-unquote, risk disease that might consider surveillance. So what do we think about very low-risk prostate cancer? The guy who has just 1 or 2 cores, for example, of Gleason grade group 1, that's 3 + 3 = 6 disease, involving less than 50% of each core with a favorable PSA density. For that man, active surveillance should be the gold standard. It's the rare acceptance that that man would not have surveillance. Why do we think that? This is a long-term data from the Johns Hopkins Prospective Surveillance Registry, about 1,800 men that have been well followed since about 1994. And most of these men were very low-risk patients. On the left is the cumulative incidence of prostate cancer metastasis or death. So if you have a metastasis or death, it'll go up here. If that metastasis or death was from prostate cancer, it's going to be in the blue. If the metastasis or death happened from any other type of incident, heart attack, something like this, it's going to be in the dotted reddish line. And what you can see is that if you survey these guys with very low risk disease, this blue line for death or metastasis from prostate cancer is virtually flat. It's just at zero. There's basically almost no events. And so that tells you that for very low risk men, they should be choosing surveillance as their initial management strategy. And as you would expect, as these are older men, and the average age is in their mid-60s, as they go on to live for 15 years, this dotted orangish line goes up because they're dying of other causes, heart disease, other malignancies, etc. Just because we are telling the patient you're going to be on active surveillance as a gold standard does not mean we're telling them you'll never need treatment. What this graph is here is showing what's the likelihood that they'll have treatment or at least have their disease reclassified as a higher risk state during surveillance. And you can see that about 5 years, about 40% of the men at 5 years have had treatment, about 50% at 10 years have had treatment. And if you look at disease reclassification, so say Gleason score 3 plus 4 equals 7, or 4 plus 3 equals 7, that's mainly what's accounting for them going towards treatment in those years. So active surveillance should be the preferred treatment strategy or management strategy for men with very low risk prostate cancer, but those men should have the expectation that they won't necessarily be on surveillance forever. By about 10 years on surveillance, half of them will probably need treatment. Yes, ma'am. Yes, sir. And actually, anyone can ask us to go. Go ahead.
So, based on the second slide, if they're getting treatment, then they're no longer on that first slide. Is that correct?
Yeah. So what happens is they are still on this slide. So essentially, yeah. So if you got treatment, that is why this thing stayed so flat. So if these people were on watchful waiting, where you didn't do anything for the very low disease, then this blue line would have started to go up. But because they were watched on surveillance, which includes biopsies, PSAs, doctor visits, all this stuff, they were intervened on, and again, at Hopkins, they were very persnickety about this, but in the community and everywhere we should be equally persnickety, they were intervened on when they showed signs of progression. So if you went 2 years through your course of diagnosis, were found to have a Gleason grade group elevation to Gleason grade group 2 or 3, had intervention, then the chance that you're going to die or metastasize from prostate cancer is absolutely low. Great, it's a great question. But it shows that the initial management strategy, and what you're bringing up too is, and I sort of maybe glossed over it, and as we talk about higher risk categories, so low risk prostate cancer is higher risk than very low risk. And that's because there's more cancer there. Even though it's low grade, there's more cancer there. We're going to see in a second that we don't really have as much data on those men. When I'm electing to put a person on surveillance, the number in my mind that I say I want at least half of the guys like him to still be on surveillance in 5 years. If I think that I'm going to have to treat that guy's cancer, if I think that next year at the confirmatory biopsy, the cancer is going to look worse and I'm going to have to treat it, then I don't want to put that guy in surveillance, right? Because in every clinician and every patient has a different time in which they would like to see if they can delay their care. But in my mind, I think to myself, can I be pretty reasonably certain that this guy's going to be on surveillance for an appreciable period of time for him to gain the benefit of having perfect or as good sexual function as he can have, as good urinary control as he had, without losing a lot of ground? If I think that they should be, they're going to need to be treated early within a couple of years, I'm not going to put them on surveillance. For very low-risk men, because they're starting out with such low amounts of low-risk disease, and because of studies like this one by the Johns Hopkins group and others, we know that it's about 50% get treatment within 5 years. If you waited for grade progression for treatment, it would probably only be 30% at 5 years. We should definitely be putting these guys on surveillance. But as we go to the other risk categories, which we're going to talk about right now in the active surveillance gray zone, these guys need more consideration. Are we putting them on surveillance, or should we treat them up front? And who are those guys? One we mentioned, so guys that have low risk disease, they have higher volume Gleason grade group 1. There's a difference between the very low risk patient with 1 core of Gleason 6 and the guy who comes in with 7 cores of Gleason 6 on their biopsy. Favorable intermediate risk men that have 3 plus 4 equals 7 disease. And then men with strong family histories of prostate cancer. So our experience with surveillance, the long-term experience we have that's a very rich experience, has really been with very low risk prostate cancer, or men on the low side of of low-risk prostate cancer. Like maybe they don't have 2 cores involved, maybe it's 3 or 4. We have very low experience that's been reported on with high volume Gleason grade group 1, so high volume low risk disease, or favorable intermediate risk disease. This comes from a review written by Dr. Sasoyan and others that looked at different surveillance programs, both in the U.S. but also Canada and other areas. And what you can see is that even though the number of patients on surveillance at Hopkins at this time of this review, 1,300, 1,000 from Sunnybrook, et cetera, the percentage of men with favorable intermediate risk disease, so Gleason score, that's how they call it, sums of 7, was 0 to 13%. So we don't really know if we can watch those guys or not. The first questions we had that started in the 90s were, can we watch any cancer? Now we've proven we can watch some cancers that are minute. The question is, how can we expand that? What do we know about these populations?
Can I ask a
Yeah.
question? Going back to the other slide, everything seems to be focused on the Gleason score and the number of cores involved. What about the, if I'm using the right word, genomics?
So we're gonna get there. That's perfect. So very low risk is pretty straightforward because it leads right into this. So very low risk is pretty straightforward because essentially it's such a low amount of disease that we know we don't have to be worried about it. But your question is perfect. You say, okay, well, what about the other things that characterize disease when you have a question? And the clinical question comes when we have, for example, that low-risk patient, 5 cores positive of Gleason's 3 + 3 = 6. PSA is still low, I can't feel disease, but 5 cores are positive. And I say, okay, well, what do I know about that patient? Well, one thing I know about that patient is we don't know a lot about that patient on surveillance. So we did a study, myself and Dr. Sasoyan and Dr. Carter and others, where we looked at, for the patients that we had on active surveillance that were low risk, not very low risk, but low risk, how much were they indicative of actual low risk patients? And so what we asked is, on our surveillance people that were low risk, only 8% had 4 or more cores involved. So of the low risk guys, 98% were just barely moving from very low risk to low risk. Whereas if we look at people we take to surgery, 50% of them had 4 or more cores involved. So we didn't study these patients well. Even with that selection bias, those patients who have low-risk prostate cancer had a 2.5 times increased chance, that's this line here, of being reclassified. This line gets steeper down if you get reclassified to Gleason grade group 3 than these folks here that were very low risk. And we know from the PROTECT trial, which was an active monitoring trial, that they also had 2.5 times increased chance of having metastatic events. So the question is, how do we then use genomics and imaging to tell us if we want to try to extend surveillance into the low risk, favorable intermediate risk state? How do we use genomics and imaging to tell us who is safe to follow and who's not? And so that's perfect. We're 2 slides away from genomics, but we'll do imaging next. So these imaging and genomics have really been a large benefit to the field in many different disease states. And we have the next session, if you're here, we'll talk about genetics and genomics in detail. But they certainly have helped in surveillance. One thing which I don't think is covered today, but you guys are probably very familiar with, is that multi-parametric MRI is starting to play a very, very large role, both in screening and diagnosis of prostate cancer, and also in the surveillance and treatment of prostate cancer. A multi-parametric MRI is an MRI where there's at least 2 parameters taken. So you'll go into the scanner and they'll do some sequences that look at the anatomy, T1, T2 sequences they're called. Then they'll add some, they'll look at the diffusion of water. They'll look at the, diffusion weighted imaging it's called, and see if water moves into and out of cancers differently than benign areas. And they may give you contrast, and do something called dynamic contrast enhancement. Based on those metrics, the radiologist will give a lesion, so a questionable area in the prostate, a score on the prostate imaging radiology scoring system, PIRADS, and that score will go from 1 to 5. The radiologist says, this is most likely benign, or it's highly suspicious if you're a 5. Data from previous clinical trials, I just showed one here on the Precision trial, shows that if the radiologist thinks that a lesion is a PIRADS 5, highly suspicious, not only are they usually right, 90% of the time that's cancer, but about 70 plus 80% of those patients will actually have intermediate risk or higher cancer. So then you could ask, well, for active surveillance, if my guy, say, hasn't had an MRI, but has been diagnosed with this multiple cores of Gleason 6 disease, would an MRI help me tell if I can have him stay on surveillance or if they need to come off surveillance and have treatment. And it was a small study, but what they showed is that in a small study done in California, that people with a PIRADS 5 lesion that were on active surveillance, so highly suspicious lesion, from other trials we know about 80% chance of being intermediate risk disease. Within 2.5 years of being on surveillance, all of those patients were reclassified to Gleason grade group 3 or higher. So all of them went to unfavorable intermediate risk disease. So in my practice, with very rare exceptions, if you have a PIRADS 5 lesion, so the radiologist is saying there's a big tumor there, I do not recommend surveillance for those people because there's too many, even though Gleason grade group 1, 3 plus 3 equals 6, has a lot of indolent properties, there's too many of those cancer unstable cells around. They're going to probably cause a problem in the next couple of years. And obviously you can argue things about, well, how old is the patient and what are their wishes and whatever, but by and large, PIRADS 5 I don't like. The other thing is, like, say that, are all Gleason scores the same? When the person, this is your question, when you're looking under the microscope, and someone says this is Gleason 3 plus 3 equals 6, are they actually all indolent tumors? And there, I think, is a misconception out there that all the low-grade cancers don't have any metastatic potential. I think that's a misconception. And I think that based on a lot of the genomic studies. This is a complicated, yes, sir?
So if you had a PIRADS 5 lesion and it was biopsy and it was benign, you shouldn't.
So that's a great question. So like if, so the caveat is if the cancer is contained within that PIRADS 5 lesion. So if you had a PIRADS 5 and they biopsied it and they found just inflammation, and you went to someone who does a lot of fusion biopsies or you're confident in the fusion, those people I do have surveillance. But if you have, say you had 2 cores of Gleason 6 that were found, we've done your MRI, and now it shows a PIRADS 5 lesion in the area of your Gleason 6, you probably need treatment. The other way of doing it, what I hope things are going towards, is we get the MRI before your first biopsy, which is what I try to do with all my patients, but a lot of the payers haven't quite got there yet. Now we do your first biopsy, and say we find just Gleason 6 in that PIRADS 5 lesion. I tell you, yes, you have low-risk disease, but that lesion is a PIRADS 5 because there's capsular abutment, because it's a big lesion, it's greater than a centimeter, and I'm worried, even though it's all low grade, there's so much of it that, I think that you should think about treatment. Does that make sense? And what you're saying is, like, this needle is moving, because I hope that precision trial is over a year old, and the hope is that everybody is going to have an MRI before their biopsy, because that's what the precision trials showed, not to sidetrack too much. It showed that if you have an MRI first, 30% of people could avoid biopsies. You would miss the diagnosis of very low-risk disease, but you'd actually find more intermediate risk and higher grade disease doing less biopsies. So MRI first should be the tail of the tape. We're in flux right now. I've been doing fusion biopsies myself for 5 years plus. But a lot of the insurance companies are dealing with, do they want to cover the MRI? A lot of the practitioners don't have the equipment to do it, and there's things in those realms.
Excuse me.
Yes, sir.
So I'm one of those guys that basically felt as though they had 2 diagnoses of cancer. So I had a 12-core biopsy done in my urologist's office. 3 of the cores came back with 3 Gleason score.
3 plus 3 equals 6.
Yeah, and one of them was a slight, close to 7, so I do have a Gleason 7 on the better side of it. But
So you had 3 cores, 2 of 6, and 1 was 3, 4, 7.
yeah. So at any rate, but that was prior to an MRI.
So just for the audience, so he basically said that he has favorable intermediate risk prostate cancer diagnosis, and that was prior to the MRI. Then you had an MRI.
Then I had the MRI, and they found a PIRADS 5.
Yeah.
And that, when they told me that, that took me back to day 1 when I started again, because I had had the genomics testing done between that, where it predicted that only a 3% chance of growth within the next 10 years.
Right.
Which I was very optimistic about. So then to find out that there was a spot that they essentially missed, it's my understanding it's in part of the prostate where they typically don't do a biopsy.
Yeah, and it could be. So sometimes it's not, sometimes it is. Like this is one of my patients where I'm showing the fusion biopsy. This lesion was at the roof of his prostate, and usually our biopsies are down here on the floor, down here. And so this guy's lesion would have been completely missed by standard 12 core. And so, or it would have been undersampled. And there's a lot of questions about, like, when you undersample a lesion, or if you're catching the edge of it, the genomics there showed, are they really the genomics of the whole lesion? So then what you should have had is another biopsy coming up?
So then I had, I got into a study at NIH where they did the fusion MRI and the guided biopsy, where then they did 14 to 16 cores of the 3 that were the lower intermediate risk, as well as directly into the Priads 5.
Yeah, you don't always have to have 16 cores when you do those fusion biopsies, but go on. And they found? We're waiting on path? What did they find? Can you tell us or no?
They found that he suggested that he didn't feel that, even though he would, because he's a surgeon, he would suggest surgery.
When they did the fusion biopsy of the Polaris 5 lesion, was the Polaris 5 lesion still 3 + 3 = 6 or 3 + 4 = 7?
I don't remember. I have it all here. I
No,
misplaced my
okay.
glasses. So
I don't want to put you on the spot. But you would be a case where you're showing 2 important things. One, like you said, if you had just had the MRI first and gone to someone like Peter Pinto at NIH and gotten your fusion biopsy, or to me and gotten your fusion biopsy, gosh, it would have saved a lot. Two biopsies are not terrible, but they're not great. Cost of the genomic testing would have been done. We're going to talk about that in this slide. It would have been done on the better biopsy as opposed to the first biopsy. And so that's why if there's one thing that we have to advocate out there, it's MRI first. And a lot of people say, the clinicians will say, well, we're not ready. We didn't make the capital expenditure to buy the equipment. We're not really trained on it yet. Or the MRI centers will say, well, we don't do prostate MRIs, or we don't know what the protocols are. But I think they have to all get ready, because there's level 1 evidence saying it's better, so that we don't have your situation. But for you, you're tenuous. Just note that in one small study with the Polaris 5 lesion, there was a lot of reclassification in a short period of time. Because the reason it was Polaris 5 was that it was big and it touched the capsule of the prostate. So you're playing with fire a little bit. Your genomics can help you. So there are sometimes like deal breakers and whatever that genomics can help. And what am I talking about there? So genomics, and there's going to be a whole hour on this next one, but genomics is basically looking at gene expression patterns within the cells. And you can help you do 2 things. It can figure out which cancers that are Gleason grade group 1 are more aggressive and need treatment, and which cancers that are Gleason grade group 1 or even Gleason grade group 2, like your 347, are less aggressive and can be potentially surveyed. And first is the question are all low-grade cancers indolent? And the answer is no, in my opinion. This is a complicated slide, but it basically looked at the UCSF active surveillance cohort, and each guy from that cohort is a line in yellow. And then it looked at people that had prostate cancer that was treated by prostatectomy, and they had bad pathology, like disease that was already extraprostatic in the seminal vesicles, or they had a biochemical recurrence. And those are all these blue lines that are going down. Then they looked across 18 different signatures for gene expression that correlated with metastasis. The worse your signature was, the higher the height of these lines are. And what they saw is a couple of things. One is most of these prognostic signatures, these signatures that when they're higher, the cancer is worse, track together. Blue is good, red is bad. Most of these guys track together. So you can think of them as one signature or an aggregate signature almost. They saw that most of the low-grade cancers from the UCSF, the yellow, were in the blue zone. They had low risk genomic signatures. But 7% of them were up here in the red zone with lots of other patients that had bad pathology at the time of prostatectomy. And when we looked at this in a study that Dr. Soy and I did for cell cycle progression scores, which is the Polaris test, and when Dr. Klein and colleagues looked at this with the Oncotype DX GPS scores, they again find that about 7% of the candidates for surveillance have genomic scores that look like cancers that we would never want to follow. And so those people probably should not be followed by active surveillance, because we think that they're going to have a fast progression rate quickly. Similarly, and I'll just breeze over this, these are those 3 commercial tests, and we'll talk about this in the next session. Similarly, there are some scores that are so good that, on the genomic level, that those cancers might be followed safely, even when they have some bad characteristics. This is the cell cycle progression scores and like a modification of it that takes in some clinical factors called CCR. And there is a threshold in the Polaris test, which is if you guys want me to, I can go over this in more detail, maybe I should. The Polaris test, these three tests, Polaris, CCP, Oncotype DX gives a genomic prostate score, and Decipher, which is a genomic classifier. These tests are tests that are done on the tissue. So when it's done the biopsy, you're going to do this test on the tissue. And you're going to ask, what are the gene expression patterns of the genes in that cancer? And they're going to be gauged on things that drive cancer, whether it be cell cycle progression or how fast the cell divides for Polaris, or it's a mix of cell proliferation and androgen signaling, stromal response, and cellular organization for Oncotype DX, or a mix of other gene probes for Decipher. These are independent prognostic tests. So beyond Gleason score, beyond how many cores, everything they're saying, in addition to that, we're giving you information about how risky that prostate cancer is. And my point is, if these tests tell you that you are going to be 2 standard deviations away from the mean, you're in the most risky group, even though your Gleason grade group is 3 + 3 = 6, I would take a lot of caution in having that person on surveillance. There's always exceptions that prove the rule, and there's no prospective randomized study that has looked at this yet, but I think that the evidence is very strong.
Is that standard procedure now? How long
So-
has that been standard procedure?
Standard procedure is a big question. So like, how long have I been using these tests? I would say about 3 years or 4 years in earnest. Some practices, so in my practice, we've developed protocols around like, I think there's big questions for low-risk men and for favorable intermediate-risk men, and I have trouble making a decision without the aid of some of these genomic tests. I can make a decision for them, but it's not going to be complete. And so I tell my pathologist on almost all of those men to get one of these 3 tests. They are widely available. They have good coverage, but in terms of standard, I don't know what it takes to make something standard. So for example, the MRI prior to initial biopsy is supported by level 1 evidence from a multinational randomized controlled trial, building on a decade worth of data suggesting that it would have worked, right? It's published about 2 years ago. If you have Blue Shield Blue Cross in Texas, you can't get an MRI before biopsy. You're going to have to pay out of pocket. So like, when does something that should be standard become standard? I don't know. And the evidence for MRI is much stronger than the evidence for these tests. These tests are definitely helpful, but this doesn't have level 1 evidence. So that's a question. Or they may have talked about, using earlier in the day, they may have talked about people with hormone-sensitive prostate cancer needing intensification of therapy by not just Lupron or Eligard, but adding on abiraterone or Xtandi or apalutamide, and then doing that increases their overall survival. There's now 4 papers more showing that level 1 evidence showing that happen. And you say, well, is that standardly adopted? It appears to be adopted in the minority of patients, not the majority. So I don't know, it takes a lot of steps for something to become standard.
So the MRI and the genomics generally isn't covered by insurance?
So MRI after diagnosis is, MRI before diagnosis is up and down. Medicare, and every insurance is different, every different area, but in my area, Medicare will cover MRI prior to biopsy, because in the end, in some places Blue Shield Blue Cross does not, some Cigna does, some United Health does. In the end, like this gentleman, you actually save money by doing MRI first, right? The genomics is harder because it's used for precision medicine. And we'll see as we go to the precision medicine talk, if you guys stick around the next hour, who are you affecting? So you're going to do, when you run this test, you're only going to find something that really changes management, maybe at the extremes, in 7% of the people. In 7% of the people, it's going to change management. So you're going to order the test on everyone to change management in 7%. And then there's a question of cost.
But that test has, all of the invasive part of the testing has been done.
Now, I'm preaching to the choir. I use this on all my patients, but what will it take to make it standard? If you look at studies in breast, with Oncotype DX breast, it's become more and more standard as they've done these clinical trials linked to the test. So we'll have to see. But anyways, like there are bad scores that you shouldn't watch people with prostate cancer for, there's also scores that are good enough that maybe you can watch those cancers. So like this gentleman said, if his disease risk was in this low range where there were no events that people who were concerned during managed, or if on the Oncotype DX prostate your scores are in the low range, this last tertile here, where 74% can avoid upgrading, that can help you decide which one of these more risky patients can you watch. That's genomics. How about host factors, which is genetics? So genetics is like every cell in your body, what's being affected. And how about things about your age or race? So I'm not going to go into the data much here, but I'll tell you, young age does not disqualify you from surveillance. Now, there was a thought, like, I don't want to watch someone who's 50, they're at the highest risk. But the reality is that's not true. They have more confident immune systems, and by and large, it does not make a risk factor for them to have more progression with surveillance. African American race does not appear to be, if you look at people that get the MRI done, get the genomics, get good screening, it does not appear to be a factor that tells us to not survey these men. We should be able to survey these men. I think in this group, from the data I've seen, MRI is particularly important because there's some of them will have more anterior cancers that can be more easily missed. What does have a big role is genetics, and primarily BRCA2. So this is going to be a minority of men with favorable risk disease that have a germline BRCA2 mutation. But if you have it, it makes a big difference. These are guys from that same active surveillance population that we talked about before at Johns Hopkins, and they looked at their BRCA2 status. This is reclassification. We'll look at just this bottom curve. This is like the amount of people, the percentage of people that got reclassified to 4 + 3 = 7 unfavorable intermediate risk disease or higher over time. If you were not a BRCA2 carrier, so if you're in the 98% that do not carry that gene in the germline, your reclassification rate is pretty low. You've got to wait 10 years to get to 20% reclassified as 4 + 3 = 7 or greater. If you're a BRCA2 carrier, then at 2 years, you're at 20% have been reclassified into 4 + 3 = 7 or higher. And so I think patients with BRCA2 mutations, which are in the minority, should really be counseled that they maybe do not want to watch their prostate cancer at all and elect for treatment even if they have small volume disease, because the disease can be unpredictable and unstable. So in the last part of the talk, I want to talk about, we only have 12 minutes, I want to talk about where we're going. So the whole point of surveillance was we want to not treat with a whole gland therapy, because whole gland therapies like radiation or surgery will cause side effects, urinary side effects, sexual side effects, bowel side effects, potentially with radiation. And those side effects are undesirable. And so we're going to do surveillance so we can delay those side effects until we need to treat, and the squeeze is worth the juice on that. So where are we going in the future? Where we're going to go is, what if we had therapies that could cure the disease early on with low effect on sexual function and low effect on urinary control, and not even need to do surveillance for these favorable risk men? And there's been a couple of different avenues that have been explored. One is focal therapy, that we'll talk about in a second. Like I said, with MRI coming on board and becoming better, if we think that we actually can understand or map where the cancer is, can we start to target where the cancer is? That's the idea of focal therapy. And most urologists think this is going to be a standard option soon. And the other thing is, how about therapeutics that have low morbidity, so they don't cause a lot of harm for the patients, they're systemic, and maybe treat the whole prostate, but with low morbidity. So focal therapy, there's multiple modalities that are saying, like, why, the neurovascular bundles live down here, that controls erection. Rectum is down here, obviously. Urinary sphincter is here, that controls continence. Why do we need to treat the whole gland? Why can we not just treat where the cancer is, whether it's here, here, and here? There's lots of different focal therapy strategies that have been put forth using heat or freezing, and they're all in different stages of their development in terms of the evidence supporting them. Some of them have even gone to randomized controlled trials. And the one that's most complicated to explain is the one that's gone through the randomized controlled trial. So unfortunately, I'll have to explain it. Yeah, but you guys will catch on. And that's the vascular targeted photodynamic therapy. So what that is they give the patient a drug that goes in their whole body, including the prostate. But that drug doesn't become active unless you put a specific wavelength of light on that drug. And when that drug becomes active, it then destroys the vasculature around the tissue and kills that tissue. And so they will give the patient this drug, and then they'll put probes, like little needle sticks, into the prostate where the cancer is, and then they'll put the wavelength of light that activates that therapy. And that's called, because it's targeted by those little sticks you put in, It's photodynamic because it's activated by the light waves, and it's affecting the vasculature, which is then cutting off his blood supply, killing the cancer. So that's why it's called vascular targeted photodynamic therapy. And there was a randomized controlled multi-institutional trial performed of this therapy. It was reported a couple of years ago and then had a refresh of the outcomes. The green line is people that were, all these guys were surveillance candidates, mostly low risk, some people even on the lower side of low risk. The green line is people who got the vascular photodynamic therapy. This orangish line is people who were just on surveillance. And this looks at the amount of people going to whole land treatment. So going to treatment. What you can see is a threefold reduction in the amount of people going to whole land treatment if they got the vascular photodynamic therapy. And when they looked, Dr. Gill and others a couple of years ago looked at what were the side effects. The erectile function and incontinence were the same between these two groups at 2 years at least. So kind of very promising that you could be free from radical therapy for an extended period of time with no side effects. And it is important to note that it's not all the way there. Focal therapy has not gotten to where it's all the way there. I'll skip over this quickly, but this is the results of using HIFU for intermediate risk disease, also showing good cancer control. We're not all the way there because we don't understand, with long-term follow-up, are these people inevitably going to develop cancer in other places of their prostate? So we don't understand the biology of the soil. Like, does this guy have a prostate that's just good at making cancers? And are we sort of, is a squeeze worth the juice and kicking the can down the road? Does that count? And we also don't know exactly how much tumor to treat it appropriately so you could limit costs. Treat them once and be done. We haven't done the genomics and genetics to understand that. That's going to be part of it. Part of it is with new imaging modalities as well. But it's I think a very exciting place for more research, and it's really developing, and it may be a therapeutic option for many in the future. The second is looking at how about things, if we don't understand the soil, what can we do to affect the soil, or what can we do to affect the whole prostate? And there's clinical trials that have gone on to look at this. An example of a behavioral intervention is the meal trial for vegetable consumption by Dr. Parsons and others. And that was just kind of encouraging people to eat more vegetables, essentially, in their diet, and maybe that would slow the progression of prostate cancer. In that trial, it did not. When they reported out, they saw no effect. But it's a good idea, and it can be tweaked and still keep trying things like that in a trial sort of manner where we can actually follow the patients. There was a trial called Kinetics, which gave people on surveillance enzalutamide for about a year, I think, and said if we give them this kind of heavy drug for a year, could it cure their cancer forever? And that's fully accrued, and we're going to see what happens later. It gets a little bit away from the idea of we want to give you a treatment that has very little side effects, because enzalutamide has fairly significant side effects. And there's ongoing trials with immunotherapy that actually may have very little side effects. Like I mentioned, I'm involved with the Mary Crowley Cancer Research Center down in Dallas. We're one of the sites for a multi-institutional trial with Provenge in active surveillance. This is called the Provenge trial. So Provenge, which a lot of you are familiar with, is a cellular dendritic cell therapy where they found that they took out the patient's antigen-presenting cells, so the cells that teach the immune system, took them to Sunday school and taught them how to recognize prostate cancer, and then put them back into the patient's body. That would extend the overall survival for men with castrate-resistant metastatic prostate cancer. And on that basis, it was approved by the FDA several years ago for that. What they noticed was there was very low toxicity of getting that Provenge, that it was not a very toxic treatment. They also noticed that the lower your PSA was when you got the Provenge, the more survival benefit it gave patients. They also noticed, this is a side point, that African Americans seem to respond to that Provenge better than Caucasians. But mainly because the morbidity was so low, and in other words, it was so safe, they said, why don't we bring this into our surveillance population? If you don't give people the flu vaccine once it's, the flu is all blown up, you give them immunotherapy early. And they designed this trial where it's 450 patients that have either low risk or favorable intermediate risk disease, randomized to get Provenge, which is syphilis T, or just be on active surveillance and monitor them closely. The target was 450 patients. I think about 4 or 5 months ago, they overshot the target. We had about 500 plus patients on trial. It's ongoing. I've been very encouraged by my initial results, but we'll see. It's going to take a few years to report outcomes. And the FDA has been working with them to say, look, if at 3 years you show us that the guys that got Provenge have less or no cancer on their biopsies and stayed on surveillance, we might expand your indication. So imagine a scenario where, for you, because you would have qualified for this trial, where you could just get an immunotherapy and not have to do surgery or radiation, not have any side effects really, just a little bit of light disruption to get 3 infusions and 3 plasmaphereses, and then just be done with it. That's a little bit hopeful. It's probably going to end up, I think it's going to end up working, but it's not going to be, one treatment fits all like everything in medicine. But it's very exciting. In our last minute or so, I'll just go over the summary and take some questions. So active surveillance is the monitoring of disease with the intent to cure. And the monitoring means frequent biopsies. Like people escape on surveillance. Sometimes it's biology, their genetics, the genomic score, etc. Most of the time when I've had people have bad outcomes in surveillance, it's like the patient disappeared, they were diagnosed somewhere, they were told, you can watch this, and then they just disappeared. And 5 years later, they show up to your clinic and you see them and you say, what's going on? They're like, I diagnosed 5 years ago, and you ask them, ever have a biopsy since then? They said, no, and then it's worse than you thought, because you waited too long. Active surveillance is a standard of care for very low-risk prostate cancer. I think that is really true. But men with higher volume low-risk disease or favorable intermediate-risk disease are less well-studied, and we have to use all the tools we can to see if they're really qualified for surveillance or not. I think there's a lot of interesting things on the horizon. Focal therapy, emerging therapy like immunotherapies are really going to open the field here and maybe save a lot of guys from having treatments that cause morbidity. Thanks very much. Thanks for the excellent questions during the talk. And please, I think we have time for one or two more.
Is that Tulsa? There's some Tulsa thing with that?
So Tulsa is a type of HIFU. It's a type of heat type of radiation where it's transurethral, so it will send out the radiation from the urethra out, or not radiation, I should say, the heat waves, the ultrasound heat waves. They were first looking at it as a way to treat BPH, but then they just recently did a trial looking at how effective it was for full-blown prostate cancer. And then obviously they're going to go from that to do focal therapy. Yes, sir?
Yeah, so I want to bring my 13-year-old younger self here, and he's 51. He's got a Gleason 3+3 in 2 cores, 10% involvement. I think it was about a 40-gram prostate. Seem like a candidate now?
Yeah. So that person should do is very low risk disease. The kissing density was less than 0.1. Had two cores, and they were both Gleason 236. That person should be on surveillance now. That person is the ideal surveillance candidate for sure.
Now let's time travel back 13 years. You take 13 years of your knowledge away. What does he do then?
It was unclear because that person right now looks like they're not even 60 or maybe barely. So it's like a 50-year-old guy with that kind of disease.
51.
Yeah, a lot of people would say, look, never better chance to cure than now. The cancer's here. We don't really know. We haven't had the long enough data to know what's going to happen. And surveillance should certainly have been discussed, but wouldn't have to necessarily be done. And if they said, what's your family history? What are your preferences? Because they didn't know. I still would have put that person on surveillance. It's going to be progressive. Dr. Carter would have put that person on surveillance, I think, because it's going to be progressive. But a lot of people said we just don't have the data mature yet.
If I remember correctly, Johns Hopkins was just starting to put people in active surveillance if they were 65.
So in '94 they started, and even though they preferred older men, they have put all men on surveillance. They preferred, there was definitely a leaning towards older men because they felt like, what if we miss an opportunity for cure? This person's going to have a problem the rest of their life. The big difference now, and for you as a survivor and as an advocate, is to say now that's the standard of care. I mean,
Right,
medicine
yeah.
is we are learning as we go, just like you guys, the patients, And so now that person should certainly get the standard of care surveillance. What's the chance that you have been treated within the first 10 years? About 50% chance you have been treated by now, but 50% chance you wouldn't have been treated by now. And the reason to even more so say do surveillance is say you did get treated now, maybe you would qualify for a clinical trial, maybe we try something else with less morbidity. And there's going to be people.
I was a hell of a lot healthier 13 years ago too.
That's the other argument. You can do better nerve sparing with lower risk disease. You recover a lot faster when you're 50 than you are when you're 60. But all that into account, I think for your case, or the other, this hypothetical person 13 years ago, surveillance would be number one. And then but if they showed signs of disease progression, then
Right.
Thank you. Thank
So
you.
is that the end of your 1 o'clock session?
That's the end of the 1 o'clock
Okay.
session because it is 2:01.
Yes. Thank you so much.